And next speaker is Dr. Phoebe, and he shows verified consensus of surgical difficulty and risk management strategies. Okay, thank you.
Okay, thank you for your introduction. I'd also like to thank all the international guests who have filled up this room. And I'm very excited to witness this global effort to look for the best practice for the patients with cholangitis and cholecystitis. And my talk today, it's kind of changing gear from what have been discussed today. And I'm going to talk about surgical difficulty and risk management strategies during lab chole. So my first topic would be why surgical difficulty during lab chole important. Okay, so we've been discussing about TJ13 and TJ18 all the way, and there's a lot of suggestions. And for example, early versus delayed lab chole. This is a level A evidence that is that early lab chole is recommended. But why do we need this? Because when we know that if it's delayed lab chole, we have a lot of complications. Why a lot of complications happen? It's because the operation becomes difficult. And how about open conversion? It says in the guidelines that we should never hesitate to convert to open, because when they experience difficulties in performing lab chole. Okay, so now here comes the word difficulty. And how about optimal time for cholecystectomy following PTGBD? There's no evidence, but it says when acute inflammatory response subsides. So that's nearly equal to when lab chole becomes less difficult. All right, so what is difficult? And this is a very exciting task force launched by SAGES, the Safe Cholecystectomy Program. And there are 6 suggested strategies for surgeons, and starting from the use of the critical view of safety. And there's all these 6 suggestions are extremely important, but I just want to point out 2. So and there's one suggestion saying that recognize when the dissection is approaching a zone of significant risk, which is based on the judgment of the attending surgeon. Do we know if everybody judged the same? And it also says that get help from another surgeon when the dissection or conditions are difficult. We all agree with this, but how could you tell if the surgeon is recognizing that, that he or she is facing a difficult situation? So what is difficulty in lab chole? So we've been putting a lot of effort to this Japan, Korea, and Taiwan project to define the surgical difficulty. So so far, we've been publishing 3 reports, and this is led by Dr. Takada, Dr. Han, and also Dr. Huan. So we did a survey, this large-scale survey to look for how surgeons look at their own lab choles. And we got thankfully, we got a very high response rate. And these were the questions. I'm not going to go too far, but basically, what do you think about when your surgery becomes difficult during lab chole? So there are several conventional surrogate markers of difficulty. And for duration of surgery and estimated blood loss, there's no agreement. There was statistically significant difference among countries. And how about safety measures and recognition of landmarks, such as intraop cholangiogram, or the critical view of safety, identification of Rovier's sulcus, and exposure of this SSN layer, which is pretty much common in the East Asian countries. Unfortunately, all these 4 items, we didn't find any agreement. We were surprised to see this. And how about, what is the clinical scenarios when you decide to convert to open cholecystectomy? The only item that reached consensus was that certain degree of agreement was that if you see damage to adjacent organs or bile duct injury, that's when you convert. Okay, so everybody will probably agree with this, but it's already done. It's too late. And all the other things, extensive operative time, extensive blood loss, extensive adhesion, severe fibrosis, and scarring in callus triangle area. Basically, everybody sees it in different ways. So all these items, the importance is not the same for everyone. So that's why we have to set a certain consensus for surgical difficulty. So that brought us to conduct a Delphi study on surgical difficulty during lab chole based on interoperative findings. So we want to find something objective, something that can be used universal. So we circulated this survey over 500 expert LC lap chole surgeons in Japan, Korea, and Taiwan. And we asked the surgeons to grade each item based on 7-stage scale. So this is the demographics of the respondents. And again, we thank all the participants. So we had a very high response rate, over 90%. So intraoperative objective findings that were break down to 3 categories. The first one is factors related to inflammation of the gallbladder. The second one is additional findings of the gallbladder and its surroundings. And then the final category was intra-abdominal factors unrelated to inflammation of the gallbladder. So we did this survey and asked the surgeons to grade each of these items in a 7-stage scale. So we defined the Delphi consensus for this survey to have interquartile range of overall responses within 2. And the second criteria was to over 2/3 of the responses concentrated within a median of 1. And thankfully, for all these 25 items, we reached a Delphi consensus. So at least for this over 500 expert lap chole surgeons agreed that all these items are indeed very important and directly correlated with surgical difficulty during lap chole. So based on these results, we were able to assign points to each item for the 25 items. So this is something that have already been published. And now that brings us to the final topic. We moved on to safe cholecystectomy. How can we save patients from going into bile duct injuries? So this Delphi study, why we did this, once again, because bile duct injuries, there continue to be devastating problems after lap chole, and you see a number of reports describing requiring liver resection just because of the bile duct injuries, and there are cases even reporting liver transplants for bile duct injuries. And I personally experienced a handful of patients while I was doing my transplant fellowship in Miami that several patients needed a transplant because they got trouble with this bile duct injury. And some of the patients, we couldn't even bring them to operation because he or she had a severe infection while on the waiting list. So those things should not happen anymore. So for this survey, we did a Delphi study. Over 600, asking over 600 expert LC lap chole surgeons, and the questions asked were: what kind of situation is bile duct injury likely to happen during lap chole? The second part is: what are the important landmarks or intraoperative findings that raise a red flag for surgeons for the high risk of bile duct injuries? And what are the appropriate surgical techniques to avoid or reduce the risk of bile duct injuries? So this time we asked the surgeons to grade each questions in a 5-stage scale. So this is the respondent demographics. And about this time the response rate was about 60% in the first round, and for the second round it was about 75%. So for this survey, the Delphi consensus was defined as the interquartile range of overall response within 2. And the second criteria was over 80% of responses graded either 4 or 5. That means that they think that those items are very important and directly correlated with high risk of bile duct injuries. So when to stop? Of these 7 items, there were 2 items that reached the consensus. The first one was severe fibrosis and scarring in callus triangle area due to inflammation. The second one was impacted gallstone in the confluence of the cystic, common hepatic, and common bile duct. So these 2 were the situations that that surgeons should stop and think, okay, and think about other options. And where to stop? So this question is related with landmarks during lab chole to look for. Where to stop? There were two items that reached consensus. First one was, of course, a critical view of safety, and the second one was Kyle's triangle area. I'm not saying that all the rest that did not reach consensus is not important. It's different. All these items were raised, considered as important, but of all these important items, these two were selected exclusively, extremely important among these items. Okay, and how can we prevent this type of bile duct injuries? And there were three ways to prevent. One was effective retraction of the gallbladder to develop a plane in the collar triangle area. So basically, you have to have a good tension between the tissues to perform safe lab chole. And then the second part, always obtaining the critical view of safety. The third part is that when you start seeing some bleeding, you don't want to do too much bovie or clipping. And just primarily, you should stick to compression and avoid excessive use of bovies. And then, what are the bailout procedures when you are stuck, when the operation is stuck, if you're in a difficult situation? Of these four bailout procedures, the only procedure that reached the consensus was open conversion. So again, I think there's a lot of papers on bailout procedures, and I think this is a matter of this is an area of continuing controversy, and this is something that we have to look for as a future question, a future area of investigation. Okay. Now I'm approaching to the final slides. So we did find strong positive correlation between surgical difficulty and the risk of bile duct injuries, which is not that surprising. Okay, so obviously, so this study is based on the Japan, Korea, Taiwan collaborative study. The second survey was we invited U.S. and other countries as well. So we need to continue to consolidate global efforts to help the patients in the desperate need. I'd like to conclude my presentation with a famous saying by Albert Einstein: "In the middle of difficulty lies opportunity." This is the word that Dr. Takata keeps reminding the team members of the multinational project. Thank you for your kind attention.
Thank you for presentation. Is there any comment or question? Okay. Steve first.
So congratulations on all the work that you've done in this area. Just one very small thing. VBI means vasculobiliary injury, and it's a definite term, which means a bile duct injury and a vascular injury. So if your correspondents took that as meaning a vasculobiliary injury, it could have affected the outcome of your study.
I see.
The other thing is that it's important to remember that when you do a Delphi, what you get back is opinion. Right. You don't get data. Right. And one has to be very careful drawing conclusions on opinion. For instance, we showed that the worst vasculobiliary injuries, what we call extreme vasculobiliary injuries, in which half the patients die, the rest of the patients need a right or a left hepatectomy, occurs when you do a top-down cholecystectomy, when you cannot, in a small shrunken gallbladder where you can't dissect the hepatocytic triangle. That's the worst injury. Yet, a lot of the surgeons who responded to this thought that a top-down cholecystectomy was a good way to deal with that very problem. So I think we have to be very, very careful interpreting exactly what this means.
Yeah, thank you for raising a very important question, comments. Actually, for the first part, I heard from Dr. Wakabayashi that you pointed out that vascular injury should fall into the bile duct injury, which I thought initially we thought that vascular biliary injury will cover all bile-duct injuries, but it was the other way around. So we'll make sure that we use terms correctly. And the second part, actually, that is the limitation of this survey. It's still a survey, and we really don't know if this is something that all the respondents really do act this way in the clinical situation. So it does not contain any kinds of patient data. So that's a significant limitation of this survey.
Go ahead.
Horacio Asman, Mayo Clinic, Florida. Question, in your demographics, what was the age of the people answering? Do you remember that?
We have the data, but we did not do any analysis. We just made sure that when we had to define what is expert lap chole surgeons, and the cutoff line was over 200 cases of lap chole lifetime experience.
Okay. The reason why I ask, and this is what I was commenting to Steve, I'm still puzzled that people, in fact, in one of your questions was the only consensus reachment, are saying about converting to an open. What do you do when you convert to an open that an expert laparoscopic surgeon wouldn't do laparoscopic? Not that I am saying that conversion to an open is a complication. I don't believe that. I don't think it is a complication. I'm just saying if you know that it is a difficult gallbladder and you need to think about exit strategies, you don't need to convert to understand that you're at the point that you need to do extra strategies. Then I think it's going to be a matter of education and changing thought process, because we all said and advocated convert to an open if you can't. But that generation of surgeons that feels more comfortable doing open cholecystectomies should be passing.
Right. I'm on the same page. Myself, open cholecystectomy, the number of open cholecystectomy way below compared to lap chole. We have to look into if there's any generation gap between the answer of if the answers are different among generations. That's something I have to look into.
Again, Henry Pitt from Temple. And I think this work is excellent, and I think it does help answer the question of what difficulty is. But if we go down the bile duct injury track, I think we have to remember there's literature for 3 decades that suggests that a lot of the bile duct injuries occur when the surgeon thinks everything was fine, and the anatomy was fine, and the operative note reads perfectly. And the work, I think, of Larry Way and others, that it's a misperception of what's going on is very crucial in this area. And any way we comment on this, we should comment about the problem of misperception. Dr. Han?
For the question Dr. Horacio Asman has raised, I think it is very important. Actually, when we have analyzed the data, the very experienced surgeon who has over 1,000 laparoscopistomy do not think open conversion do anything. So they think they can do laparoscopically, open laparoscopy they are saying. So it's a very good question. So I think that if we have to find something is very difficult, I think we have to maybe divide into the very beginner, intermediate, and very experienced. Many experienced surgeons think that open conversion is not useful, and but if the surgeon is not good enough intermediate, like 500 to 1,000 laparoscopy, open conversion may help.
Yeah.
Okay. Jimenez, very short. And then one more comment.
No. Congrats for your presentation. Is it the same way of Horacio and you? Is it possible to talk about the consensus with 79% said open and 75% said partial cholecystectomy?
Yes. So this is just, we're not saying
I vote partial.
Yeah. So we're not just saying that just because we did not reach a consensus, the other procedures are useless. We're not saying that. We just mentioned that this was the only one that reached a consensus in a certain definition. And actually, my talk will be the introduction for what Dr. Wakabayashi is going to talk from now on. So I think we're now in the right time, right place to discuss about what kind of procedures we should keep in mind to help and save the patients.
Last comment, no rebuttal. Horatio.
It's just an addition of what we were saying. The only reason why I'm emphasizing about the conversion to open is because the TG13 do have a clear recommendation conversion to open, and it may be time to change it.
Yes.
I
Okay.
totally agree, yes.
Thank you for good advice.
Thank you.
Thank you. Thank you very much.